Is this visible?
Yes, doctor.
Okay, great. We'll be talking about palliative medicine and non-oncology. Now, what we'll be covering here are the main symptoms that are present in all the various systems. So we'll go system-wise, and we'll keep it an open discussion. So please feel free to chip in wherever you have a suggestion or a question also. Yeah. Uh, so just a bit of revision. What is palliative medicine? Palliative medicine is defined as an approach that improves the quality of life in patients, both adults and in children, and their families who are facing problems with life-limiting illnesses. Now, life-limiting illnesses here would encompass everything and not just cancer patients, which forms a very small part of the whole population that we are dealing with. Now, this, according to the definition, is to be made by early detection, correct assessment of symptoms, and managing them. So it can be physical symptoms, psychological symptoms, or spiritual symptoms. Uh, so initially, if you look at how palliative medicine has evolved over the past couple of decades, would be that initially it was thought to be only peri-death of the patient, and that was it. They gave support during the very terminal stage of the patient's trajectory. But over the years, it has evolved to start from the very beginning of the disease, that is at diagnosis, and then continuing it over to the terminal stage, and even has extended beyond that to bereavement support as after the death of the patient. So now how we look at palliative medicine is this bow tie model, which is like a very integrated form of palliative medicine, where the disease management goes hand in hand with symptom management and palliative care, and it can go either way. It can go to rehabilitation and survivorship, or end of life care and bereavement support. So the competencies in any palliative care physician would be to be able to describe what a palliative approach for care is, which is basically a holistic care that is given to a patient. Being able to manage and address all the symptoms, including pain and others like fatigue, anxiety, depression, and anorexia, cachexia. To be able to participate in good care of the dying patient and their family. So basically, identifying whether the patient is dying or not, or approaching his or her death, then what are the common signs that are associated with natural dying process, and how would you prepare and educate the family members and the caregivers for the death of the patient, and also extends it to the proper care of the body after the death of the patient. Then being able to address psychosocial and spiritual needs. So there are various tools that are available, and approaches how would you manage those symptoms and needs. End of life care decision making according to your legal and bioethical framework in your current area. So some of you might be working in institutes where they have a proper protocol or proforma on how to manage these. So going according to that. Uh, Being able to communicate, which forms a very good cornerstone of palliative medicine. So communicating effectively and well with the patient's families and other caregivers, always knowing that any symptom is multidimensional, and addressing the source of the suffering rather than just the symptoms itself. And at the same time, having a self-awareness about your own burnout and having a good self-care plan while taking care of the patient, because if you're not your 100%, you won't be able to give your 100% for the patients. Now, coming to the four roads of death. So how usually it approaches, it's usually sudden death, which is like some fatal event that is occurring and you die. Uh, Graph B and graph C both point towards terminal illness actually, but type B would be mostly seen in cancer patients where they are fairly well maintained during their treatment phase and gradual decline over the period of time. Type C is what we are going to deal with, which is organ failures or non-oncology part of our chronic illnesses where you have your respiratory diseases, heart diseases, liver diseases, etc. Where what happens is that because the organ is slowly declining over time, your functionality is also declining, and there are troughs and plateaus, as you can see. So at every dip, the functionality of the person as a whole goes down. It comes back up, but it never reaches the baseline again. So as you can see in graph C, it is not coming back to its normal high of in function as the time goes on. So whenever it goes down, it comes back up again, but never back to the normal. It's near normal. So what happens in general is that because it's such a slow decline over years together, you fail to realize that your functionality has come down, or the patient fails to realize that his functionality has come down over the period and that it is not as normal as it was before the disease started. So prognostication becomes a big issue in non-oncology patients, and also explaining that their disease has increased so much or deteriorated so much that there is not much that we could do before for the patient. So it becomes a very challenging part from making the patient and the relatives understand that this is a chronic illness similar to cancer, though the trajectory is very different because there is so many dips and ups throughout the trajectory. And D is old age basically. So it is frailty where the functionality has already uh, decreasing because of the age and then eventually leads to death. Now, where all palliative medicine plays a role, it would be all organ failures or organ disorders, your neurodegenerative disorders, advanced rheumatological diseases, advanced cancer, as we all know, and even prolonged ICU stay with multi-organ failures, which are not responding to treatment any further. Now, we've seen all this. This is the backdrop of what we are dealing with. So can you think of any barriers that the patients or the relatives might have, or even the physician, as the primary physicians would have for referring or for advising these patients for palliative care? So let's take it from a physician's perspective. Can you think of any barriers from a physician's perspective that might, you know, that might be present? So anyone, just type it in the chat box, or you can just unmute and answer whether you can think of any barriers from a physician's perspective.
We are getting comments in the chat box. So Dr. Kurt says misconception that palliative care is only end of life care.
Yes, so that's excellent point. Anyone else?
To be in denial that there is no cure.
Okay. Anyone else wants to chip in? Okay. So let's go one by one. One is, as you said, the wait. Just give me a minute.
Okay.
Yeah. So basically, even the physicians would want it to be curable always. So they want to go for that cure, and they'll feel like it's giving up on the patients, and that they might take it as a personal failure as to why can I not treat this patient and why he or she is deteriorating so much. Lack of knowledge about what palliative medicine entails in general. So, and misconception, as you correctly said, that, it's not just end of life. Okay, now can you think about from a caregiver's perspective? What would be the, you know, barrier from a caregiver perspective. They can be the immediate relatives or they can be
Ma'am, Dr. Darshana says no much information.
okay. So lack of information from their side as well. Yes. Anything else?
Doubts about recovery.
Okay. We saw the trajectory as well, right? So the trajectory is also very uneven. So it's difficult for them to also, or for physicians also to pinpoint that, yeah, this would be the last terminal event. So that is there. Uh, so as I said, the disease trajectory, uh, you would want everything to be done for your loved ones. So they are like, why should we give up? Guilt that they won't be giving the treatment and all, and also a societal pressure of what others will say if I stop giving whatever said treatment and just continue with palliative care.
There are
Okay.
few more comments, ma'am. Shall I read it out for you?
Yes.
So Dr. Sonia says they may try all modes looking for cure first. Dr.
Mm,
Kurt says during peaks the patient is doing well without treatment
mm,
and the family doesn't want to give up or lose the person.
right. Excellent points altogether. So you basically get a picture of what might be going on in the caregiver's head at a time of decision making. Right. So these are the backdrops, and now we'll be looking at the disease. So no, not going into the details of all the diseases because that is a different scenario altogether, but all the common diseases in each systems, and then we'll look at all the major symptoms that arise and how we would manage them. So coming to central nervous system, you would generally get your dementias, you have your Parkinson's disease, you have traumatic brain injuries and stroke patients. So all of them are basically a chronic set of patients who have had these diseases for a long period of time. Traumatic brain injuries are acute patients, but the injury sustained are something that would cause long-term rehabilitation and long-term care. So the common symptoms that we generally see are seizures. You have your plagias or paresis, so hemipara or quadri. You have your dystonias, hypertonia or hypotonia, dysphasias, and aphasias. So these are the common symptoms. And coming to management, so rehabilitation should be offered to the patient all throughout. So it's not just system-wise throughout any disease trajectory. Rehabilitative measures go a long way in helping patients cope up with the symptoms better. So rehabilitative measures should be offered to all the patients. Uh, for dystonias, especially hypertonias, muscle relaxants are a good source of relief from the pain that they are going through. So muscle relaxants or baclofen because it's centrally acting. So those help a lot. Analgesics, wherever required, including opium or opioids, wherever required, should be given to the patient. It should not be thought of that it's not cancer pain, so we will not give opioids. They should be offered and used wherever necessary. Optimizing anti-epileptics if necessary, especially if the seizure activities is a lot. Giving them SOS dose, SOS formulation for MEDAS, intranasal sprays or injectable if that is what they prefer in case of emergency should be given and educated about. So they should be well informed about the use. Now coming to the last two. So speech aids is where you kind of, especially in aphasias or locked-in syndromes, what happens is the difficulty in communicating with the patient. So wishes and preferences cannot be discussed. So speech aids go a long way in helping in communicating with the patient. Now there are multiple ways of doing it. Simple ones are asking them direct yes and no questions, and if they are able to blink, then blink once for yes and two for no, such and all. So asking them direct questions and giving them certain cues for answering yes or no. Others are, depends on the availability in the area as well, but there are newer ones which are laser pointed, so they spell out the words and all that, or computerized as well. So, but it depends upon the availability. So you need to find out what is available and how you can utilize those said speech aids in your resource limited situation. Also, getting help from speech therapist and swallowing therapist go a long way in helping these patients being able to speak, or if that is possible, feasible. Now, PEG insertion or NG insertion is a bit controversial. Uh, do you have any comments on that? Would you go for PEG insertion or NG insertion? Where would you prefer NG? Where would you prefer PEG insertion?
Participants, you can type your responses in the chat box, or else you can even unmute and answer.
NG insertion won't be possible in case of there any deformity of the cervical spine, or if the patient's position is not proper in the insertion of NG tube. Especially in cases, I've encountered one case of Parkinson's or any mouth tumors, oral or nasopharynx tumors, laryngeal tumors, where the pathway is blocked. So in such cases, PEG tube is preferable.
Okay.
Only depends on the cost also, because
Right.
insertion.
Right. So
PEG,
financial issues and
yeah.
your anatomical issues. Okay. Apart from that, where sometimes you might feel that, is there any point where you feel that you would not want to go for either PEG or NG insertion? Anyone? Sorry, did I lose you?
Any
Neither when the
malabsorptions or digestive issues or intestinal tumors, where we give the patient feeds and he's not able to digest or metabolize the feed later on.
Okay.
when the patient is really end of stage and probably has few hours or days, then even drinking water sometimes is hard. So something just to keep the mouth wet or something like an ice cube. So then there's no nutritional support required at that moment.
Okay. Anything else?
Aspiration.
Dr. Aiza, we can't hear you clearly. Can you be a bit more louder? So Dr. Aiza says aspiration.
Yeah. So what about aspiration? So it's basically like they say that PEG insertion helps in preventing microaspirations. That's what the literature says. It can be controversial, but in general, they say that since NG tube is in C2, so your sphincter remains open, your gastroesophageal one. So it might proceed for micro aspiration. So PEG is better than NG. That's what it says. But we have a lot of financial issues. So it is kind of depends on from patient to patient which they would prefer and would be able to afford. Okay. So as you said, PEG versus NG, sometimes, especially if they are end of life and have poor prognosis, neither of them would be okay, depending on how the relatives and the patient feel about it. But it is okay to withhold either of them if the prognosis or if the patient is end of life. Okay. Anything else that you want to add? Apart from this, any questions?
Ma'am, there were few comments in the chat box. So Dr. Kurth says PEG insertion, for example, in an infant who repeatedly removes the NG tube. And Dr. Upapulnath mentions that patient not cooperating with NG tube insertion. Dr. Dilip says it can be because of phobia.
Yes, true. So basically, what you need to remember is that you need to take into account the patient's wishes and preferences and values as well, and on what his treatment should be. So, if the patient is unable to communicate or is not coherent, then the wishes and preferences of the caregivers, the main decision makers in the care of the patient is. Sorry. Okay. Proceeding to cardiovascular. So basically you have your heart failures, your congenital heart diseases, which oftentimes may lead to isomengerization. So the commonest symptoms would be your breathlessness, chest pain or heaviness, palpitation, heart racing, which might be perceived as anxiety, edema, cough, fatigue, and sleep disturbances. So coming to management, again, rehabilitation all across the board. Opioids, would you give opioids in these patients? Would opioid be used in patients with cardiovascular diseases having a severe pain or breathlessness? Anyone?
That's what they're saying. Dr. Raisa says we cannot give methadone.
Okay. Why? You're correct. Why? Why would you not give methadone?
Because of QT prolongation in methadone.
Right. So it might it might cause a lot of distress after giving it. Okay. And Dr. Dilip, I would give it for breathlessness. So morphine would help with the breathlessness associated with heart failures as well. So you'll just have to monitor the dose that you're giving, but you can give it for breathlessness and pain. Okay, so opioids wherever necessary, as we saw, and diuretics, as we know, it kind of takes away the preload. So that would help with the symptom management. Beta blockers are a bit of controversial thing in the sense that we don't want it to have an additional effect on the heart. So wherever necessary, you can give beta blockers and oxygen support. Okay. Now, respiratory diseases, we have all these end-stage COPD, ILD. You have your cor pulmonaire and pulmonary embolism. The symptoms overlap a lot with the cardiovascular ones. And this management is almost the same. So with addition of few like an acetylcysteine or steroids would help a lot in managing respiratory symptoms. And opioids here mainly would be for breathlessness and also the pain associated with excessive use of your thoracic muscles. Antipsychotics might be necessary, especially if the patients are agitated a lot and restless a lot. But yeah, so these are cardiovascular and respiratory symptoms. For opioids in these cases, you need to remember that the only thing you need to monitor is that they do not have over toxicity or intoxication. You can up the dose as and when required. The current research says up to 10 milligrams of morphine, but higher doses have shown benefit. So you need to individualize it to patient. And diuretics can help with, especially if there is pulmonary edema, they help. And also there is some research on inhalational furosemide for breathlessness. So that helps in certain patients, not all of them. Certain patients it has shown good results. So according to your patient population, if it's responding, then you might want to continue that. Coming to hepatobiliary, you have your liver cirrhosis and liver failure. And the general symptoms are nausea, vomiting, fatigue, your weight loss, and all the signs of liver failures. Rehabilitative measures again. Here there are multiple choices. So you have to have your antiemetics, antipruritic agents, and laxatives. So antiemetic, what would be the choice and why? Why would you prefer those antiemetics? So we all agree that there is a lot of nausea and vomiting involved in liver diseases. So what would be your antiemetic of choice? What is one that you give generally in your daily in your practice?
Ondansetron.
Ondansetron. Excellent. So why do you prefer ondansetron over, let's say, domperidone?
Ondansetron is a 5-HT3 receptor blocker, so it acts in the central receptors.
Yes. So anything that acts centrally would work for nausea, vomiting, because of hepatobiliary causes, or rather because of your liver disorders. So metoclopramide also, because it acts centrally. So either 5-HT3, or you can give your prokinetics. So metoclopramide is a good choice, but you have to be careful whether or not they have allergic reactions to that. So always make sure that they don't, and then give that. Otherwise, you'll end up in a lot of more symptoms than you want. So, and Ondem is very easily available even over the counter. So ondansetron is a good choice. Anything else that you can think of which acts centrally for nausea, vomiting?
Steroids can also act centrally for relieving nausea, vomiting.
Yeah, but in hepatic causes, do you think it's equally effective in hepatic causes? Haloperidol, excellent. So antipsychotics, basically, haloperidol or your olanzapine. They also act centrally, dopamine through via dopaminergic system. So it's a good antiemetic to be used in hepatic causes. Okay. Pruritus is another common symptoms, especially with end-stage liver disorders. So I've already written it. So sertraline is the first line of management for pruritus associated with hepatic failure. Second line is your dapsone, and ondansetron is the third line. So they can be used according to availability, and sertraline works wonders for pruritus. Like one dose and the itching has gone more than half of it. So a good choice in pruritus. Laxative, what is a common laxative that we give for patients with hepatic NCAF?
Lactulose.
Lactulose. So basically what it does is, what does it prevent?
It prevents the accumulation of ammonia in the gut and its absorption into the bloodstream.
Yes, so basically to avoid all that, right? So lactulose is the preferred laxative of choice. Supportive measures here I mean ascitic tapping if required, diuretics for edema if required, protein supplements or albumin infusions if required. So all those supportive measures. Then coming to renal, again, you have your end-stage kidney diseases because of various causes. symptoms more often would overlap your hepatic ones. So you have your nausea, vomiting, decreased appetite, fatigue, decreased urine output, which leads to signs of fluid overload, which can be edema, chest pain, breathlessness, headache, high blood pressure, pruritus, muscle twitches or cramps, sleep disturbances. Now, so for nausea vomiting, it's similar to that of hepatic cause. You'll use something that is here centrally acting. So your ondansetron, metoclopramide, or haloperidol. Decreased appetite, it's not per se that you can give a lot of medications for decreased appetite or fatigue. It's mostly rehabilitation in terms of light exercises and small frequent diet. So that's not a very medicated approach to these symptoms. Decreased urine output and signs of fluid overload can be managed with medications or renal replacement therapies like dialysis. Pruritus here, what would be your drug of choice here? Any guesses? This is actually a very odd one. So basically, UVA light is preferred therapy for pruritus for renal symptoms. Then local application of capsaicin can sometimes be helpful. And sertraline is third line of management. Muscle twitches and cramps, you can give analgesics as and when required. And sleep disturbances, you can use medications if required in terms of benzodiazepines or melatonin if required. Any questions till now? Sorry, what do you want me to repeat? UVA therapy, UVA, UVB therapy for pruritus is helpful for pruritus of renal causes. And and sertraline is the third line. You can use naloxone as well here, but sertraline is the third line. I'll send you the copy of, I'll send you a screenshot of the treatment. I'll send it to, so you can have like a reference for it. Yeah. Then you have, okay, so we got over the management. Again, lactulose is preferred here for similar reasons. So those were the symptoms. One of the main symptoms that is associated with most of the systems that we saw is breathlessness, and it's important to just focus on that. So this is the breathing, thinking, functioning model of breathlessness given by Spathius. So what he suggested was so frequency of lactulose is basically you start off with 30 ml once a day, and then you can increase it according to the need of the patient. So that's how you titrate it. Now coming to breathing, thinking, functioning model. So basically what he suggested was that there is a breathing issue, there is the thoughts that are associated with the breathing issues and the functionality of the person as a whole. So what he said that because there is inefficient breathing and increased work of breathing, there is increased respiratory rate and use of accessory muscles with dynamic hyperinflation. So it all leads to, again, inefficient breathing and increased work of breathing. Then the thoughts associated are generally your anxiety and distress and panicky feeling, which are usually associated with your thoughts of dying and misconceptions that you have regarding your diseases, and a lot of past memories and past experiences which influence all this. So all these lead to, again, increased anxiety and distress, which again leads to a lot of breathlessness. And because there is your reduced activity and functionality and tendency to self-isolate, which again leads to a lot of negative thoughts, there is deconditioning of all the muscles in your body, which again leads to deconditioning of chest wall muscles and accessory muscles, which lead to inefficient breathing and breathlessness in general. So they say that when you want to manage breathlessness, you manage all three of them to manage breathlessness effectively. So for breathing, you help them, like, let's say maybe they require a BiPAP support intermittently. So give them that BiPAP support intermittently. to help with that breathlessness. Or you do mindfulness therapy, you do your conditioning therapies and controlled breathing and handheld band and all those measures to help with the breathing functionality. Also give them light exercises and pacing and support for moving around and encouraging them throughout the process. Your meditation, yoga for the thoughts, and anxiety management for their thinking process. So you manage all these three effectively, you manage breathlessness effectively. So sorry, indications for, yes. So as I said, supportive measures wherever required. So CLD management goes on along with your supportive measures as palliative medicine physician. So you manage your NCEF as you manage your NCEF, and then additionally, if you want to add extra, then you give all those medications. Okay, so coming to end of life care, sorry, I have just ended this lecture. Yeah. Okay, so coming to end of life care, basically ISCCM in India, that is the Indian Society of Critical Care Medicine, they gave us this pathway for end of life care. It's a long pathway, it's an initial pathway. They have upgraded it according to the recent Supreme Court hearing. So basically what they said was, if there is a prognostic uncertainty, you kind of offer palliative care as early as possible to the relatives and the patient. And if there is consensus amongst everyone involved, then you have gotten approval from your institutional ethic board, medical institutional ethic board, and they are okay with everything and there is transparency and everything. If the option of withholding and withdrawing is given and accepted by the relatives or the patient, that should be done, and good end of life care and palliative care should be given to the patient. So that is what all of that gichidi pichidi khichdi was, and that is a simplified version. So if there is a prognostic uncertainty and you finally discuss and get a consensus among all the treating physicians involved, you have a honest and early discussion about the prognosis with the patient, if coherent, or with the main caretaker and relative. You thus establish the goals of care for the patient, and if necessary, you withhold or withdraw life-sustaining treatment and offer effective and good comfort care to the patient and appropriate support to the family. And you document all this and make sure that you yourself also realize, and you make the patient or the relatives involved also realize that this is not the decision. If at any particular time they feel that, no, I don't want this anymore, I want to go back to aggressive management, aggressive treatment, that is still an option. So make sure that they know that it is a to and fro process and you can modify it as and when needed. So as you can see, in non-oncology, there's a long way that we need to go, and it's still in early phases of its being implemented in India. So we have to work together to make sure that it happens. Thank you. Any questions that you might have, please feel free to ask.
Yes, participants, if you have any questions, you can post it in the chat box, and then maybe after some time we can move into the case presentation. Dr. Aiza, would you like to unmute and ask your questions? Yes, so Dr. Raiza has a question in the chat box, ma'am. Is there any indication for ursodeoxycholic acid?
Yes, so yes, you use it wherever required. As I said earlier, so wherever you feel that it will help with not only ursodeoxycholic acid, but if you want to give your Lola and all L-aspartate, ornithine, whichever. So you feel that that would help with the symptoms of the patient, that can be given and should be offered to the patient. You should not withhold any treatment that might be beneficial for the patient. So yes. Anything else?
Any more questions? Dr. Nafisa? So, ma'am, there's one question. I'll read it out for you. So, for pediatric age group, could I start with milk of magnesia as first line laxative or directly lactulose?
I think I would prefer lactulose, and maybe you can go for a combination after that. But yeah, I mean, lactulose generally works out well for them. And if you want, you can even add in Dulcolax for the patient, Bisafolil or something like that. Yeah. And pediatric population generally start off with a lower dose than the adult ones. And usually they kind of have good responses with lower doses as well. And if you feel that the child is highly constipated, then go for suppositories beforehand. Otherwise, there's local injuries.
So, there's one more question. Is it necessary to give albumin after ascitic tapping?
Not always, but if you feel that it's low, and since you'll be tapping in a large amount of fluid, then you might as well give supplements. But again, injectable albumin stays in the system only for 24 hours. Like if you give it today, it'll last up the effect will last up till only tomorrow. So you have to give oral supplements as well. So start off with a good hepatic diet for the patient.
Any more questions? If not, I think we can, ma'am, we can move with the case presentation for today. We have Dr. Varsha Vamaikar joining us for the case presentation. Welcome you, Dr. Varsha, and it's over to you.
Good afternoon, everyone. Am I audible?
Yes.
So let me introduce myself first. I'm Dr. Varsha Vamaikar. I'm working as a medical officer at Primary Health Center Kurtari, which is under the DHS, Goa. Can you kindly enable screen sharing option?
Gayatri will be moving the slides for you from here. Gayatri, next slide, please.
Okay.
Yes, please go ahead.
So this patient was an elderly 82-year-old female. She was admitted at the Primary Health Center. She was a case of cerebrovascular accident with a catheter-associated urinary tract infection with hypertension and diabetes mellitus. So presenting complaints, she was a known case of hypertension since 20 years and diabetes mellitus since 16 years. And she had a stroke, ischemic vascular accident, and she was bedridden for the past 6 months. Now, since 3 days prior, she started getting fever with chills, and the relatives noticed high-colored and turbid urine for the past 6 to 7 days. History of presenting illness. The patient had a stroke 6 months back, and since then the patient is bedridden, and she has a Foley's catheter in situ. So she started getting fever associated with chills, and relatives noticed high-colored and turbid urine, for which also there was a history of bed sore wound over lumbosacral region since the past 1 month. Because of this complaint, she was admitted at the district hospital for the same. She was treated with antibiotics over there, and then she was transferred to the lower center, that is our primary health center, for completion of 3 days course of injection linezolid. Next slide, please. General examination. The patient was conscious, oriented, lying in bed. Temperature of 98.2, pulse was 82 per minute, regular. BP was 149 by 86. Urine output was reduced to 400 500 ml per day. The patient is on nasogastric tube feeds. Systemic examination, RS was clear. Cardiovascular system, S1, S2 was normal, no murmur. Per abdomen soft, non-tender. CNS, there was grade 0 power in the right lower limb and grade 2 in the right upper limb. There was deviation of angle of knob to the left. Sensations were absent on the right side. Local examination of the bed sore. There was a bed sore present in the lumbosacral region. around 7 to 5 centimeters in size, and slough was present. Next slide. Significant investigations which were done at our primary health centers, the HP was 9.2, total count was increased 11,400 cells, differential count neutrophils were 62, lymphocytes 34, urine routine pus cells were present, albumin was present, blood urea was 19, serum creat was 0.2, RBSL was 172. Since she had fever, SMP NS1 was done, which was negative. Next slide. At PHC, she received IV fluids, injection linezolid 600 mg BD for 3 days, injection pantoprazole 40 mg OD, injection human ectopid 888, paracetamol 1 gram SOS, tablet paracetamol 500 mg 6 RD, tablet ecosprin 150 mg OD, tablet clopidogrel 75 mg OD, tablet atorvastatin 40 mg OD, syrup disodium citrate 10 ml TDS, tablet amlodipine 5 mg OD, tablet metformin 500 mg TDS, tablet glimepiride 1 mg TDS. Also, daily dressing of bed sore was done at the PHC during the admission time. Now, psychosocial aspects in this patient. The patient is bedridden and she is taken care of by the son, who is 62-year-old, who is himself retired, and he is suffering from hypertension, diabetes, and ischemic heart disease. She is taken care of by the son as well as the daughter-in-law. She has 2 married daughters who stay far away from her, so they come once in a while, that is once in a week, to visit her. She is dependent on her son for all of her daily routine function. Daily dressing of the bed sore is done at home by her son and daughter-in-law. She feels like she is burdened to her children and is upset most of the time of the day. Son is tired of taking care of his mother as he feels that she is never going to improve. Also, he has to spend considerable amount of money when she is admitted at hospital for transport and some of the medications, although most of the treatment provided is free of cost at the hospital. Next slide. Her medications for chronic conditions, she is taking insulin at home, 888, which is administered by her son. Then tablet ecosprin 150 mg OD, clopidogrel 75 mg OD, tablet amlodipine 5 mg OD, tablet metformin 500 mg TDS, glimepiride 1 mg TDS, and atorvastatin 40 mg HS. The main concern in this patient is, since she is bedridden, how to improve the quality of life in this patient. Then treatment of various acute and associated chronic conditions. Then there is also uncertainty regarding the course of illness as to whether she is going to improve or whether she is going to remain like that. Also addressing the depression and psychological issues in this patient. Summary: 82-year-old bedridden elderly female with urinary tract infection and bed sore, who is completely dependent on her children for her day-to-day activities. Discussion points. How can we improve the quality of life in this patient? And how to communicate with this patient regarding the prognosis or course of the disease? Thank you.
Thank you, Dr. Vasha, for presenting the case. I now open this for discussion, and I request all the participants to post their comments, their questions and suggestions in the chat box, so that from that we can take this discussion forward. So here there are already 2 discussion points, and you can post your comments on the same, and also based on the case that Dr. Vasha has presented, you can post your inputs, and you can even raise your hand and ask questions to Dr. Vasha or Dr. Rutula. We are all here to support you on that. So the first question is, how can we improve the quality of life in this patient? So participants, comment your views on that, like what comes to your mind, because you have heard Dr. Vasha presenting the case scenario, the patient story. So what comes to your mind when you think about improving the quality of life for this patient? And Dr. Varsha, you can also let us know your inputs.
Dr. Hashmat, can I speak?
Yes, Dr. Kalyani, please go ahead.
Okay, as regards to this case, she's an 82-year-old female. So she's old. So regarding the quality of life, we can see that she's hygienically okay, as in she's got bed sores, UTIs. So what we can do is ask for when the last catheter was changed, whether there is a need for catheter per se, because we can give her a trial of without like block the catheter, see if she can sense her bladder, so that if there is the bladder sensations are still intact despite stroke, then it would be better if we take the catheter out permanently. But if still she doesn't have any sensation, then the catheter has to be changed frequently. So the relatives can be counseled as to how to keep the area clean, when to take the catheter out. Since primary health center is closer to where they stay, they can come to primary health center and get their catheters changed. Second, regarding the ulcer, the bed sore. So we could ask if there is the patient position is changed every 2 hours or not. Also, everyday dressing, and see that the flies don't sit on the open wound, diabetes control, and also a water mattress would be better so as to avoid more bed sores in this case. As the patient is conscious, cooperative, and she can speak, I think there might be some residual speech, some problems because she has deviation of mouth also. So there might be stasis of food in her mouth, so that can be cleaned, hygiene can be maintained. Her dehydration if present, because dehydration can even give rise to recurrent UTIs. So dehydration status also can be checked. The relatives can be asked to give her some fluids, something like that. This is regarding the improving quality of life. And also, since they mentioned that she also has relatives, I mean, she has daughters. So the daughters could be asked to visit her so that she's not constantly thinking about her problems, just to cheer her up. If she has other relatives, can they can come and meet her, because she's not going to improve anytime soon. So in her present scenario, at least the rest of her life can be made cheerful.
Yes,
Yeah,
that's wonderful, Dr. Kalyani. That's a wonderful point. And we have few other comments in the chat box. Dr. Umrila saying physiotherapy, bladder wash. Dr. Kurt saying educating family for proper care to prevent further bed sores and mattress. Dr. Raiza saying oral care, proper cleaning of the wound and dressing of the wound, proper urine catheter change. If we avoid catheter, bed sore may worse. Yes, that's a point definitely to consider. And Dr. Upakul Nath mentioning frequent changing positions to prevent bed sores. Yes, that's what we advise. Changing the position every second hourly for bedridden patients. And Dr. Raiza mentions the bowel habits should be regular. Yes. Dr. Rutula, would you like to add your comments on the same?
I agree with everyone. And another, maybe if it is feasible, then maybe a caretaker throughout the day to take off the burden from the son, because he was also a bit burned out, is what I felt. So someone to help him along the journey. So if feasible and if affordable, a caretaker for the mother throughout the day.
Yes.
As an additional support. It does not have to be like the caretaker is the only person taking care. It's just that it'll give an additional support to the son and everyone in the family as well.
Yes, Dr. Rutula, because we were able to see that when she presented regarding the psychosocial aspects, caregiver fatigue is something that we can see there. So maybe we can offer some respite care for them at a hospice or even in a palliative care setting where we can take care of this patient for 2 or 3 days, where the caregiver can also go back and have their own time and then come back. So respite care is being provided in many of the palliative care institutions in certain hospice where patients like this with serious health related suffering, they will come to us and we keep them in a home atmosphere. So that was one thing might be we have to consider here. Thank you, Dr. Rutula, for pointing that out. And Dr. Kurt says we have to work out a plan where the sisters could maybe be more of involved in the care of the mother. Yes, in the comments, in the psychosocial aspects, we could see that the sisters, they come just weekly once. Maybe if they can take care of her for a few days, then the son would have a little bit of time for them, for their family, because this will actually affect the relationship between the son as well as his wife. They are together caring for for the mother. So all of this is very, very important. Dr. Rutula, there's one question from Dr. Varsha. She's asking, what's the role of end of life care in this patient?
Maybe you can have the discussion with the patient or with the son I mean, whoever is the main decision maker in this situation. Ideally, it should be with the patient, but if the patient is not of that not that kind of a authoritative person in the family, then you'll have to discuss it with who is. And you might want to discuss about the further goals of care, as in if requiring multiple hospitalizations frequently, then you might want to put in a cap at what should be done and what should not be done. So all the options should be discussed in this patient, in the further plan of this patient. Now, end of life care, do you feel that this person is dying imminently within, let's say a week or so?
No, ma'am. No,
Yeah, so
she
that
may
is,
survive another 2 months
yeah.
also.
So, what you need to plan now is sort of like a future planning in the sense of advanced directives, because if there is so much of symptoms and issues involved, then there might be requirement for multiple hospitalizations in those last few months of her life. So you would want to set in the goals of care for the admissions. And you might also want to say, okay, if the symptoms are severe enough, then only come for admissions. You might even want to say that. Otherwise, it can be, if the option of home care is available, that should be offered to them, because majority of it can be given at home, and only if there is a terminal event or very serious or severe symptoms, they might come to the hospital. That's another option. But you'll have to discuss openly with this, I think, the son in this situation, from what I gathered through the case presentation. You might want to discuss with him that since, given the situation, she's having multiple problems, there is a chance that she would require multiple hospitalization. She would have severe symptoms which would need attention. So what should be done if, let's say, if she requires ICU admission? Would you want to go for ICU admission or not? Because the condition in general, condition does not look to be very optimistic and might not benefit. It might even cause her more distress than not. So you might want to kind of, discuss the options with the son. You might want to take his preferences into account. Sometimes they say ki nahi, nahi, aise, how are you saying that? We want everything to be done for she's my mother after all and all that. So you might want to say ki, okay, we'll do this, but let's keep a cap. We'll observe for, let's say, you can give a time limited trial. We'll do that, but if she's not improving, then we'll stop that. Or, so keep all the options open, discuss very frankly about the goals of care, and then maybe jot down advanced directive for the patient, a very informal advanced directives for the patient, and then make sure that that copy is there in the file all the time. So even in case she comes in an emergency, the attending doctor knows that this is what we've discussed and not to do this and to do that. So everything is clear basically.
Yes, Dr. Rutula. So, yeah, definitely discussing the goals of care plays a major role in managing this kind of patients. And recently, we know that in 2018, the Supreme Court of India also recognized that the right to die with dignity is a fundamental right which is protected under the Article 21. And we have the advanced medical directives and living wills, and any person who is above the age of 18 can make an advanced medical directive or a living will to plan for a time in the future when they might not be in a position to take decisions about their health. So recently that has been updated 2 days ago in our site. The advanced medical directives, the living wills have been updated, and the document is being uploaded. And I think Gayatri has recently shared that in your group also. You can click on that link where you will have the toolkit of how end of life care needs to be planned, and what are the things that we should keep in mind while we fill an advanced medical directives and all of it. So maybe you can click on that link, Gayatri. If you can share it once more below, it will be helpful for them. Yes, so that plays an important role. And in this patient, since there is, as Dr. Rutula mentioned, home care plays a major role, because an 82-year-old with the cerebrovascular accident, it will be very difficult for them to come to the hospital frequently. But if a home care team can go and visit the patient based on the priority and the vulnerability, when we go for home care, we usually categorize the patients based on their vulnerability. And if it's a high vulnerability, then we plan it in a way that we visit them often, maybe 2 weeks once or 1 week once. So maybe you can categorize this patient based on the vulnerability, and you can provide home care regularly, where the care is offered at home, and it is really more helpful for the patient as well as for the family. And with respect to the wound, I would say a proper dressing and cleaning of the wound, which has to be done twice daily, and make sure that it doesn't become even more bad, because as she was presenting, I could see that maybe it is a stage 3 pressure sore with a slough. So a proper management of that is very much needed. Otherwise, there might be some tunneling that's happening and becoming even more worsened. And also there can be several other pressure sores that can occur because she is completely bedridden. So all of that plays a very important role, where we educate the caregivers very clearly on how the wound management needs to be done. And in case if you feel that the caregivers need to be educated much better, then maybe you can plan for an inpatient admission for a few days, where you can give a caregiver education on wound management, and even physiotherapy in this patient, which is really, really important in a patient with neuropalliative care needs. So that also can be offered at your sitting. Then definitely you can go ahead and then send this patient back home. So all of this together will definitely improve the quality of life of the patient. And definitely communication plays a very important role, where you have to speak to the family, speak to the caregivers on what is expected, what is the course of the disease, the trajectory, what all can be expected in the upcoming days, and whether you want to go in for a home-based care, whether they want to go in for an hospice care, or they want to keep the mother in the ventilator. All of this has to be discussed much earlier, so that when it comes to an end-of-life situation, we are all planned and ready to take it up. So that is what I would like to add. I hope that answers your questions, and maybe if there are a few more questions also, we can take it up. I couldn't see any questions in the chat box as of now. Participants, would you like to unmute and ask any question? Yes, please go ahead, because we have time. And Dr. Rutula, I think we have covered most of the part of this discussion, especially with respect to this case. Thank you, Dr. Rutula, for patiently answering all these questions. So, Dr. Rutula, there's one question: how to prevent recurrent UTIs?
Basically maintaining a good hygiene, as we've already discussed. So maintaining a good hygiene. If there is polys inserted, then having it changed regularly, or putting it in a silicone, which is a bit of a longer time, but still having that personal hygiene maintained. That is how you would prevent recurrent ones. And yeah, I think that's about it. And if the patient is completely bedbound, then making sure that the diapers are changed frequently, or at least checked frequently, so that if it is wet, then you can change it. Yeah. But that's it, I think. It's about the hygiene rather than the medications here.
Yes, so the perineal care also plays a
Yeah.
major role.
Yeah.
Whenever we go for home care, we need to make sure that we continuously tell that to them and ask them to clean the region, keep it really clean. And also, if it's a Foley's, then we advise them to change it every 21 days once. And all of this plays an important role. The hygiene especially plays an important role in preventing a recurrent UTI. And also identifying and treating it immediately also matters a lot.
So empowering the caregivers to look for signs of UTI, or so maybe you can start off. I don't think long-term antibiotic is the solution for preventing recurrent UTIs. I mean, you might just end up with resistance rather than managing it. So I think non-pharmacological measures are more important here.
Yes, we also do not give long time antibiotics as treatment. Maybe if we identify signs and symptoms of UTI, we'll give a prophylactic dose maybe for 5 days, but not more than that. We are not going to give them a long term antibiotic for those who are, because we see patients with Foley's, even suprapubic catheters, but we don't do that. And also, there was one point about bladder wash. Generally, we don't prefer doing a bladder wash for most of the patients unless or until it is really needed. We don't do it every time when we are doing a catheterization and all. So, Dr. Rutula, would you like to add your comments on that?
Yeah, I mean, generally reserved. I mean, in the patients that I see, in case there is a lot of hematuria or, or clots in the bladder, then that is recommended. Otherwise, bladder wash not so frequent. I mean, not for UTIs.
Yes, yes. Yes, so yes, I think there are no more questions in the chat box. If there are no more doubts, I think we can close this session for today. Okay, thank you, Dr. Rutula, for joining us today for that wonderful session. I hope it was helpful for all the participants. And I thank all the participants for being really very interactive today by asking many questions, and Dr. Varsha for bringing in a wonderful case for presentation. Thank you, everyone, and over to you, Gayatri.
Thank you, Dr. Rutula ma'am and Dr. Hashmid ma'am for the wonderful session. Thank you all participants for joining us today. I hope all you got much good knowledge, much knowledge about palliative care in non-cancer illness. And we are looking forward to see you on the next session. Thank you all.
Thank you. Bye.
Thank you. Bye-bye.
Bye-bye.